1 minute. I'll just allow you. Yeah.
Okay, can you hear me?
Yes.
Yes. Okay. Well, I'll warn you, I believe my format's in 4:3 as well, so I apologize. Let me.
1 minute. I'll just allow you. Yeah.
Yes. Yep. I was unable to mute unmute myself now.
Yes.
Yes. Okay. Well, I'll warn you, I believe my format's in 4:3 as well, so I apologize.
No, that's okay. There's no problem.
Yes. Yep. I was unable to unmute myself now. Yes. Okay. Well, I'll warn you, I believe my format's in 4:3 as well, so I apologize.
No, that's okay. There's no problem.
Is everyone hearing that same replaying? Okay. I was unable to unmute myself now.
I think
You
someone
have
is
two
using,
devices connected?
yeah, exactly. Two devices, mobile as well as the laptop, or
No, now you won't hear it. Actually, I had started the screening on YouTube. So that's why we were hearing two voices, but I have now muted that. So that is fine.
Okay. So Sandeep was the cause for all of this.
All right, so this is my PowerPoint. And are you guys seeing it in presentation mode and it's advancing?
Yes, absolutely.
Okay. Great.
So what's the order going to be? Who's going first? Is it going to be Liz or Tom?
Tom, you're muted, Tom.
Oh.
Sandeep, so we have the same problem that you have to unmute them every time. Is that what's going to happen?
Absolutely. So if you mute again, then I have to again go back and unmute you. So let me see how I can play around with the settings.
Yeah, I think the few of us, if you can keep us, allow us to have that facility where we can mute and unmute ourselves. Otherwise, the background noise is going to be quite a bit.
Yeah, so I'll go first and then Liz. And then, so Alark, you say you want us to mute and unmute ourselves?
That's what I'm asking Sandeep to do, if it's possible. For now, I think just let it be, unmuted, because otherwise, if you mute yourself, then Sandeep has to unmute you time and again. So let's try out. Sandeep, are you able to work on something?
Yeah.
No, if you just click on stay muted, the notification doesn't come. So when you get that pop-up,
I think you will be able to
stay muted.
Just see.
Okay, let me try as well.
Hi.
yes, Sandeep, welcome.
Hi. Can you hear me?
Yes.
Can hear you.
Hello, everyone. So nice to see all of you.
Hello.
Hello, good morning. Good afternoon, good evening, I guess.
Yeah.
Oh, yes, late evening, good evening.
Good night.
No, not yet.
You better not say good night because you're the one doing all the introductions. So.
Yes, you're leading today, Sandeep.
Yeah.
So it's a Sandeep and Sandeep show.
So I think I have to introduce Tom and
Yeah, we'll begin.
Jennifer.
We'll begin by Sandeep. You have to introduce Tom, Jennifer, and Elizabeth, all three of them.
Okay. Okay.
And then we'll begin with Liz going first, followed by Tom going first. Sorry, I missed that.
Yeah.
Sorry, I missed that. Tom going first, followed by Elizabeth. And then we'll have a discussion, which will be led by Jayant. And then we take the next paper, which is Jennifer's. And again, a discussion.
That's the TBL guided growth.
Yeah, and then Sandeep Wadia will be moderating that discussion.
All right.
Good. I think we've checked everything out. We have a few minutes to go still.
This is the second. This is your second one?
Yes.
And how do you think it's going?
Okay, the first one we had was with Harry Kim and his partner from TSRH, Will Morris. And we reviewed two very interesting papers from there. So Harry Kim reviewed his paper on perfusion MRI for Perthes. And then Will took us through a very nice paper that they published recently on some long-term follow-ups of DDH in the age group which underwent closed and open reduction. So that was a great paper that we reviewed. And we are really looking forward to today's discussions because, again, two excellent papers from the same institution. And that just turned out, we didn't plan it that way, in fact. We didn't even realize when we invited you, Jennifer, that you were from Gillette.
Oh,
And
geez.
it was really amazing when we realized that. We said that's really excellent then. So.
And she was on our study team as well for the DFEO
Yeah.
PTA study. So yeah.
Exactly. We saw that as well.
We're a
Two
small
great papers.
institution, but we're everywhere.
No, great, absolutely. I mean, I think your paper has been the talk of the town for the last few months ever since it was published. So it's got some great traction all around the world, and we're really excited to listen to you speaking about it.
Great, thanks.
So Sandeep, can we try that, unmuting ourselves? Is that going to work, or should we just stay unmuted?
So right now I have unmuted everybody, but as we are starting the session, what I will do is I will mute everybody and then only unmute the speaker.
All right, okay.
We have 5 more minutes to go. So as we approach 8.
Before we start, I have a question, which is the first sentence of the paper, which says that the natural history of crouch, in some patient it improves and in some patient there is a deterioration. So do you think, have you seen any patient with a crouch where there is a improvement?
We have actually seen that in our Gate Lab database, yes. So an improvement without surgical treatment. So they come from improvement with strengthening programs.
So the sentence of the Kirk Graham that the natural history of the crouch is a progressive deterioration, that is not correct.
Well, I think it's more often correct than not correct, but it's not universally correct.
A smart way of putting it.
So with these sessions, do you have practicing orthopedists or do you have trainees or both?
So we have a mix of both. We are also streaming it live on YouTube, so there will be people who attend there as well. So I envisage that there'll be a mixed crowd of people from POSI as well as younger trainees as well.
And have you been able to track how many people attend?
Yes, I think towards the end we would be able to, at least on the Zoom platform, and then from YouTube, I think we can get the statistics later on. Isn't that right, Sandeep?
We had around 60 participants on the Zoom platform last week, and on the YouTube we had another about 70 views during the last week.
Okay.
So the recording goes on YouTube. They can watch it from there anytime later.
If I may ask, the 2018 paper, the cohort is part of the same 2008 cohort, is it? When you originally published on DFEO?
Some, but not exclusively. Yeah.
Yeah. There are more patients in the later study, but it does include some of the older patients.
Correct. Yep.
Yeah. All of the patients in the 2018 study are older, and we had just had more patients to choose from at that point, so we had a larger cohort.
Yeah. One of them even went to jail, I saw. So they are not doing too badly.
Is that what is picked up, Jay, from this entire study?
So one of the patients was not contactable because he was in jail.
Oh yes. Yes, we had some like that in our flow chart. Yeah.
The kids with CP are very well integrated in the US.
They're representative of the whole society.
Population. So that's like as resounding a statement as any you can make about children with cerebral palsy.
So I think it's almost 8. So I will mute everybody and then first unmute Sandeep to start with. Yeah, is it okay?
Mute. I think you should mute Jay first.
Yeah, Sandeep, can you? I have unmuted you, so maybe we can start 8 p.m. now, and we can. Yeah.
Okay. So hello everybody. POSI and Wadia Hospital. Let me welcome everybody to the Robert Buchholz paper reviews by authors, Meet the Author session. And today we have 2 excellent papers to be reviewed by their authors. We have Dr. Tom Nowacek from Gillette Children's Hospital, along with Dr. Elizabeth, who's going to review his paper on long-term outcomes of distal femoral extension osteotomy and patellar tendon advancement, which was published in the JBJS American in 2018. That will be followed by another interesting paper by Jennifer Lane, who's written about the distal tibial guided growth for anterolateral bowing of the tibia, something very exciting, which has created a lot of buzz around the world, which was published in JBJS American 2020. So before we start, let me just introduce to you today's speakers, and let me start with the lady, Dr. Elizabeth Boyer, who's a PhD in kinesiology, and she has a special interest and emphasis in biomechanics and motor control. She studied in the Iowa State University, Ames, Iowa, and she then did a postdoctoral at Gillette Children's Specialty Healthcare in Pathological Gait. And she's currently a research scientist at the Gillette Children's Specialty Healthcare. And her research primarily focuses on assessing impairments of functional outcomes of children and as well as adults with CP. So welcome, Elizabeth. Of course, Dr. Tom Nowacek needs really no introduction, who is from Gillette Children's Specialty Healthcare. He's a pediatric orthopedic surgeon specializing in CP and other complex procedures. He's the Associate Medical Director and immediate past Chief of Staff. He's a Professor of Orthopedics at the University of Minnesota. He was the first Vice President of the AACPDM. He had his education from Madison, followed by orthopedic residency in Penn State University, and he did his pediatric orthopedic fellowship in the New England Children's Hospital. He is actively involved in research and teaching for motion analysis testing methods, normal and abnormal gait, CP pathology, and CP management. And Dr. Jennifer Lane is a board certified pediatric orthopedic surgeon and associate medical director at the Gillette Children's Specialty Healthcare. And her interests include pediatric hip, especially Perthes disease, neuromuscular conditions, and limb deformities. She is originally from Minnesota, and she studied in Harvard and got a medical degree at Columbia College of Physicians and Surgeons. She did an orthopedic residency at University of California, San Francisco, and a pediatric orthopedic fellowship at Dallas, Texas, with the Texas Scottish Rite Hospital for Children. So she's going to talk to us about deformity correction using growth modulation for anterolateral bowing. So welcome all the authors, and I will hand over the session to Alaric, Rujuta, and Sandeep.
Thanks, Sandeep. Dhiren, do you want to say a few introductory words?
Without wasting much time, I would like to invite the speakers because we are more interested in the articles discussion. So, yeah, Tom, would you like to take over? Thank you.
Yes, thank you very much. It's a distinct pleasure and honor to be invited to present today along with my two co-workers. I'm just going to do a very brief introduction here about crouch gait and CP. We need to remember that there are many etiologies. Today's paper will focus on patients who have these fixed deformities, but we recognize that many patients with crouch gait do not have orthopedic problems as their primary problem. So we need to keep that in mind. We also have to remember that not all patients with crouch have short hamstrings and that there's no correlation between popliteal angle and crouch. So remember not to make your decisions about hamstring lengthening based on popliteal angle. There are many patients like this patient on the left who has significant crouch gait but does not have short hamstrings. Or does it, sorry, on the right. If you do have short hamstrings and you do a lengthening, that helps. But if you don't have short or slow hamstrings, you can make your patient worse by worsening the pelvic tilt and having knee hyperextension. So these patients that we're talking about today have severe persistent crouch in later ages. They have fixed knee contractures, as in this patient on the OR table at 20 degrees. They oftentimes have an extension lag where actively they are unable to fully extend the knee, even though they have better range of motion passively. We first did our DFEO, first one in 1994 and the first patellar advancement in 1995. Thanks to Doreen, I have these animations to share with you. The distal femoral extension osteotomy is removing a supracondylar wedge of bone to straighten the knee. The patellar advancement removes the attachment of the patellar tendon. We use a tension band to pull the patella downward and create a new spot for the tibial tubercle and insert it. We first published our technique article in 2009 in JBJS. There is an alternative technique for the patellar advancement for skeletally immature patients where the tendon is advanced underneath periosteal sleeves rather than removing a bone block. And you can see what we're shooting for with our technical outcomes. This study was our first short-term study in 2008, and this included patients who had different combinations of these procedures. And we decided after that study that we would no longer do the extension osteotomy by itself because it didn't lead to very much improvement. But the other two groups who had the combined procedures, or if you had no contracture but extension lag, you're a candidate for patellar advancement. We continue to do those today. The patellar advancement procedure is to treat the terminal knee extensor insufficiency, and in our experience, that requires an overcorrection of the patellar position. Remember again that there are other causes for crouch gait. Sometimes it's hamstrings, but not always. And for these patients, we're talking about DFEO and PTA. And with that, I'll end and turn it over to you, Liz.
Is everyone able to hear me now?
Yes, now.
Thank you. So our purpose for this study was to holistically look at various outcomes in adults who had this surgery in the past. So we looked at structure, function, activity, participation, and quality of life so that we encapsulated all domains of the ICF. Our secondary purpose was to look at how improvements in gait at short term were maintained at long term. And we hypothesized that improvements would be maintained and that the DFEO PTA group would perform or score better than the non-DFEO PTA group. And I will use this color scheme throughout: red for the DFEO PTA group, green for the non-DFEO PTA group. Our variables included physical exam, radiographs, functional outcomes, including pain, measures of mobility, quality of life and participation measures as self-reported or proxy reported. Our study design included looking in our database retrospectively for individuals who walked in crouch at baseline and had a knee flexion contracture of at least 10 degrees. And crouch was defined as 2 standard deviations more flexed than typically developing individuals at initial contact and mid-stance. We selected the middle 80% of individuals who historically have had a DFEO PTA group, so we had, a representative sample. Then they went on to have their index surgery or no treatment or other treatment in the control group. Some had a short-term visit. They were allowed to have other treatments. And then we brought them in when they were at least 20 years old and at least 8 years past their baseline or qualifying visit or surgery. Using the infographic from JBJS, I'll walk you through our results. We tried to make contact with all DFEO PTA participants, and we had successfully recruited 28 of them to come back in person. And for the control group, we had 23 return in person. Additionally, 13 individuals did not return, but they did answer questionnaires. 13 of the 28 had a short-term visit within 9 to 24 months after surgery, so we analyzed them for the repeat analysis. The majority were males. You can see our age distribution here. On average, they're about 12 or 13 at baseline. At long-term, they were in their 20s and 30s in both groups. Our average follow-up was 13 years. GMFCS level distribution included individuals in groups 1 through 4, and at baseline, they were relatively matched, as were they matched at long-term. We were unable to get gait data on 4 individuals at long-term, 1 from each group because they were no longer ambulatory, and then 2 additional individuals in the control group because of cognitive delays, and 1 individual had a gait trainer that occluded markers. Note that 5 of our 28 individuals in the DFEO PTA group did not have their surgery at Gillette, including 1 individual who went on to have a total knee replacement. While we wanted to compare apples to apples, it was not equivalent. We found that our DFEO PTA group was more severe based on these measures here than our control group. And this will be demonstrated later in some of our graphics. So on the left side, there were many benefits to the DFEO PTA group at long term. This included at the structural level when we assessed knee flexion contracture. Again, recall, we used 10 degrees as our cutoff threshold to be included in this study. Groups were matched. At long term for the DFEO PTA group, we see improvement towards neutral for the mean and median response. And at long term, the median was still 10 degrees for the control group, but you can see the variability there. Patella alta at baseline was assessed using physical exam measures. And for the DFEO PTA group, the vast majority were in alta, shown in red. For the non-DFEO PTA group, about 2/3 demonstrated alta. But please note that we had some missing data because this measure was not always collected in the 1990s and 2000s. At long term, we were able to get radiographs on nearly everyone. So we used the Cochino index to assess patella alta, baja, and normal. And at long term, as Tom said, we aim for baja positioning, and that is demonstrated objectively here. At long term for the control group, we see approximately half of them have alta. Whether this is a true change or just because we have a better sampling is unclear. Many improvements were observed in gait. So specifically, here we have our knee flexion extension curves on the y-axis for every individual in the DFEO PTA group and the gait cycle along the x-axis. And here are our controls. We can see the greater severity in the DFEO PTA group. At long term, here are everyone's data for the two groups. You can see a massive improvement in mid-stance knee extension of 24 degrees, as well as improvements of 13 degrees at initial contact. Assessing what percent or proportion of individuals walk in crouch based on our 2 standard deviation definition, approximately 1/3 versus 2/3 do. So this is a decreased or relative risk of 1/2, approximately 1/2. And these massive improvements that we see here in the DFEO PTA group was undoubtedly part of the reason why we see improvement in the gait deviation index. If you are aware, this is a comprehensive kinematic assessment of gait deviation, where larger values, 100, would represent the average typically developing child or adult, and then lower values represent atypical gait. So we have a good match at baseline between our two groups. We have a shift or an improvement at long term for the DFEO PTA group and a slight decrease shift for the control group. Our secondary purpose was to look at the baseline to short-term to long-term progression, as you recall. So for those 13 individuals, we can see the mean and standard deviation for severe crouch, a massive improvement at short-term shown in blue, and then a slight regression of about 7 degrees from short-term to long-term. While we saw these improvements in structure and function, we did not always see differences in other measures, such as measures of other functions, such as the 5-time sit to stand, which is highlighted in our gait and posture article. The functional mobility scale, reporting assistive device uses for various degrees. We can see we do not see differences between the two groups in general in how they move for the short to long distances. Similarly, for the Gillette FAQ, where lower values also represent lower mobility and 10 represent higher mobility and more independence, we did not see statistical differences at baseline in the lighter color or at long term between groups. Knee pain and arthritis were of interest, and we have the DFEO PTA group on the left, and going from dark blue to never reporting knee pain to yellow reporting daily knee pain, we can see very little and no meaningful differences between the groups. In regard to osteoarthritis of the medial and lateral and patellofemoral joints, we did not see any statistically differences between groups either. The majority had no signs or very mild signs of OA. Activity and participation were assessed by self-report, and here are some examples of different activities and participation in the community we inquired about, and we did not find differences at long-term between the groups, nor were there differences in quality of life on these 4 domains or a satisfaction with life survey. We wanted to highlight a few examples for you. We have examples of good, average, and poor outcomes in the DFEO PTA group. For the DFEO PTA group, we selected an individual in GMFCS level 1 as well as an individual in GMFCS level 3 to highlight that we can have good outcomes for both. One thing I will point out is for our poor outcome, we can see that we have some residual patella alta, which may partly explain their outcome. Here's our GMFCS level 1 example. He is at pre-op here, short term and long term. And you can see a vast improvement in knee extension and maintenance or relative maintenance at long term. So similar to our other graphs, baseline is black, blue is short term, red is long term, and this is our knee flexion extension curve. our GMSCS level 3 example of a good outcome is shown here. And his corresponding knee kinematic graphs are shown down here. And we can see relative maintenance from short-term to long-term. And if individuals qualified bilaterally, we randomly selected one side. So this happens to be his right side of interest here. Here's our average outcome. He is a GMSCS level 2. And we randomly selected the right side. And here are his corresponding graphs. Again, massive improvements in knee extension. Here's our example of a poor outcome. And you can see this individual is very stiff, and objectively we can quantify that with our kinematic curve. He only had video at short term, so we do not have a blue short-term kinematic curve for him.
Time to land.
So in summary, the DFEO PTA improves structure and functional lever outcomes in adolescents who had a surgery between 10 and 22 years old when they are young adults. However, it did not seem to influence activity participation, satisfaction with life, and some of our measures of knee, OA, and pain in early adulthood. And so with that, I would invite your questions.
Thank you very much, Dr. Boyer. I think I'm entrusted with starting to ask the questions, and then we'll take some more audience questions. Everyone can hear me?
Yes.
Yeah. So my first question was the loss to follow-up, which is expected in most long-term studies, compared to the number of patients you originally included in the cohort. Only about 25% of patients in the DFEO group and about 10% of patients from the non-DFEO group actually ended up participating in the study. Those are very low numbers of recruitment. So how, this is both to Dr. Boyer and to Dr. Novacek, how generalizable do you think these results are from the study to the larger cohort of patients that you actually treated? If only about 25% of patients in one group and 10% of patients from the other group. So 90% of patients in the non-DFEO group have not been studied in this, whereas you actually treated them. How generalizable do you think these are? Or is your sense that this is the general trend of how patients behave?
I can start by addressing some of that. So we do not, patients after they leave our institute, we do not update contact information. So even though we had, maybe 25 or 30% participation among the entire cohort, among those we were confident we had the correct contact information, phone number, email, so forth. I think our participation rate was 50 to 60%. So it was a little bit higher. We assessed match between participants and non-participants on baseline characteristics, and in general, there were not any differences. So we can assume, right, that our baseline matching, or basically the volunteer participation rates groups were similar. And so if we can assume that is likely similar, we will probably be able to assume outcomes are similar at long term, but we, of course, can't be sure. As far as the non-DFEO PTA group, as we learned, our matching methods were not sufficient. And so even though it seemed like we had a whole lot more non-DFEO PTA groups, participants, they actually probably would not have been great matches. So I think we shouldn't overgeneralize to that group in particular. And then Tom, I'll let you.
Yeah, I think two other brief comments. One is that our GMFCS at long-term was matched. So I think that was helpful. And the other factor is that as we were following, getting more and more patients coming back for follow-up, we weren't seeing significant changes in our statistics. So we felt that we were getting to a high enough number that it was representative of the sample as a whole.
Yeah, I mean, that was really the main concern is, as you know, as a practicing clinician, do you feel that the data presented in the study roughly matches with your sense as a clinician of what data you're seeing, because there shouldn't be a significant mismatch. So the other thing was that the GDI is gait deviation index for all the other participants. It is basically a summative score of how good the person's gait is. I think Dr. Boyer, sort of alluded to that. So it did improve by about 10 points at short-term follow-up, but it pretty much went back to baseline at long-term follow-up. Having said that, the contractures did not worsen. The contractures remained reasonably stable in the DFEO group. And the muscle strength, I looked at your appendix, and the muscle strength also did not worsen. It was pretty much the same. So what contributed to the going back of the GDI to the baseline, do you think? Or do you think GDI is the wrong index? I don't know, because we use GDI.
There's pros and cons of it, of course. It's nice because if you fix one thing and that makes something bad, you can kind of capture that. But it doesn't capture all planes, right? It does not capture frontal plane in the knee or.
Is it because of anterior pelvic tilt? That's one of my questions. Is because they had more anterior pelvic tilt at long-term follow-up because they had gained weight or they were weaker? I just wanted to understand why GDI became worse again at long-term follow-up. I couldn't find a reason for it.
Well, one of my theories also is that their speed tends to slow down, and GDI is not normalized by speed, but we know that speed has a main effect, like a large effect on gait kinematics. So that could be possibly one thing, right? They're walking slower, so they don't need as much knee flexion in swing phase, but we don't have a speed corrected GDI. So that could be one thing. And then, and as you alluded to, yes, pelvic tilt tends to increase after a DFEO PTA. And then Tom, welcome.
A little bit of worsening, right, of the knee kinematics as you saw, but still better than at baseline, particularly for the DFEO PTA group. So there were some other declines, maybe a little bit of anterior pelvic tilt, foot progression angles also could be a contributor.
Okay. Now questions mainly to Dr. Novacek on surgical things. So given this long-term data that DFEO PTA and non-DFEO PTA in terms of activity and participation and function, they are no different. So given a choice between performing a hamstring release at age 8 or 9 years in a GMFCS 1, 2, 3, or doing a DFEO PTA at age 14 when they will develop crouch gait, which would you rather choose? Because one is a simple operation and the other is a complicated operation. And both seem at age 20, 25 years, they seem to result in very similar levels of function and activity. So would you choose a simpler operation at age 8, 9 or a bigger operation at age 12 to 14?
It's a really, really intriguing question. And I wish it would be as easy as doing a hamstring lengthening at age 8 would obviate the need for more significant procedures later. Probably a hamstring lengthening by itself isn't enough. But I think being a little bit more proactive a little bit earlier before patients develop fixed knee contractures could be helpful. So options do include distal femoral anterior hemiepiphyseodesis. And maybe semitendinosus transfer in conjunction with patellar advancement, may be one of the ways to avoid the need for the bigger operation of the DFEO.
Thank you. So the other significant thing I picked up was the fact of the additional surgeries. I just did a quick calculation. The non-DFEO group, 30 patients, had a total of 424 additional surgeries. And the DFEO PTA group had about 28 patients, had 743 additional procedures. Now, we don't see that sort of thing in India. We barely managed to do one surgery with a bit of luck. Patients. Do you think that magnitude of intervention is really required to keep the maintain? I just want to get your sense for, each patient is having about 20 procedures on average through their, including all the Botox injections and the soft tissue releases and the lever arm dysfunction corrections and metalwork removal. I mean, it seems like a really lot of surgeries on this cohort of patients. Having now, kind of operated on a big cohort of children with CP, do you think we could reduce the number of surgeries that these children who will go into crouch are having? What is your sense? When should you intervene ideally, now that you have the benefit of hindsight?
Yeah, again, that's a very insightful question. It's true that these patients that we follow tend to have a lot of intervention. One of the things that we've seen not only in this long-term outcome study, but also in 2 others, is that our patients seem to be doing better than the reported general consensus for adults with cerebral palsy. So we're not sure, and I don't want to overstate this, but it's possible that a very aggressive approach does lead to better function in adulthood. And we know, of course, that CP is a neuropathic condition. It's permanent, irreversible. It has a lot of impacts on our patients, not just orthopedic, but strength and balance. And we also, the other thing that we're seeing is that the reality is that what I would say on the flip side, the reality is that what we do for and to patients is only responsible for a relatively small percentage of how they're doing in the longer term. So if you just look at all of us, here on the call, some of us are, we're not all in the same socioeconomic status. We don't all necessarily have the same health behaviors. Maybe some people are exercisers, other people are a little bit heavier. Maybe some people are smokers, so all of those things have big contributors to a person's long-term wellness, not just what we do in childhood.
Jay, should we take some audience questions?
Yeah, so we have one question from Mudit Shah. Could you please comment on the anterior pelvic tilt seen in your cohort postoperatively? Is there any way to correct or prevent it? And what do you tell patients knowing that they will most probably be developing anterior pelvic tilt postoperatively? So I think anterior pelvic tilt is a big concern.
It is a big concern, and it's a big concern, I think, with almost anything we do. And again, both short-term and long-term, regardless of the intervention that we look at, we tend to see worsening of pelvic tilt. So I think the best thing that we can do, and we've looked pretty hard to try to find the answers to that question about what can we do to improve it. In maybe one small group, short-term, if they had the combination of a femur derotation and a psoas lengthening, there was improvements in pelvic tilt. I'm not convinced, I don't know that was maintained in the longer term. But I do think that there's a couple of things that we need to avoid doing. And one of those is inappropriate hamstring lengthening or excessive hamstring lengthening, for example, a lateral. So none of these patients had those kinds of treatments. And, it'd be interesting to know if those had been done, or if there was a cohort that we could see, maybe the anterior pelvic tilt would be even worse. But yes, these are substantial issues. Remember that not all patients are GMFCS 1 and 2, some are GMFCS 3 and 4, and using upper extremity assisted devices, there's more forward truncaling and therefore more anterior pelvic tilt.
Thank you. So if there are any other questions directly from members?
Yes, James, who wants to ask a question. Sandeep, can we ask him to unmute himself?
Oh, sure. Hey, thanks. Hi, Tom. Yeah. Just a question for Tom and Elizabeth is that when you guys use Cochino index, was it because it's is independent of degree of flexion of the knee, or?
Yes, I mean, there's two reasons. You've hit that one exactly right. And so we have normative data to correct for the knee flexion angle. But the other thing is that in children, before skeletal maturity and before the completed growth of both the femur and tibia and also the patella, it is a method that is accurate in childhood. So this is the reason. Now, of course, in our longer term, we could have switched to a different measure, but because we had the Kashino indexes measured on our previous patients, we continued to follow that.
Yeah, because I thought Keton Duchamp in adolescence sort of like it's more independent of degree of flexion of the knee compared to Kashino. I don't know. I might be wrong in that. Yeah.
Great. Thank you, Tom and Liz and Jay.
And just I think
sure. You have another
Taral probably wants to add something.
So I just wanted to ask in the number of in the list of number of procedures which Jayan enumerated, I wanted to know were all of them orthopedic musculoskeletal procedures or some of them were even neurosurgical procedures?
They were both. We had orthopedic surgeries. We also counted implant removals in those counts. We also had Botox and other neurological injections as well as SDR. So those counts were not specifically specific to orthopedics intervention.
And Liz, I don't recall the percentage that were botulinum toxin injections, but was that a substantial percentage?
Yes.
Yeah.
Both pre-op and prior to treatment and baseline and after. Yeah, those were.
There is a very good. Yeah. Sorry, there's a very good commentary by Professor Kergraham on this article. I will forward the commentary also on the PDPods group. So it's a very good comment about how gastrosoleus lengthening probably played a big role in some of these patients deteriorating in the long term, and how it's not a good idea to do calf lengthening surgery. And also, I think Botox injection is Professor Graham's now bête noire. So he made some comments about all the excessive Botox injections that these children received. But I think, we are much wiser now regarding that.
That's true. Yep.
Great. Thank you, everyone. And I think let's move ahead to the next paper. So Jennifer's been waiting patiently in the wings. So we'll ask her to share her presentation. And the floor is all yours, Jennifer.
Okay, are you seeing that slide there?
No, not yet.
Not yet.
No, okay. How about now?
Yes.
Yeah, looks fine.
That's great.
Okay. Well, again, thank you for this honor to present today. Really pleased to have this opportunity. And we are really excited to get the word out there about this technique. We think that this may lead to a significant change in the way that these patients are approached. So to start, I'd like to thank my co-authors, Mark Dull, Susan Novotny, Andy Georgiades, and Libby Weber, excuse me. So congenital pseudoarthrosis of the tibia is an extremely rare condition, and greater than 60% of cases have been reported to be associated with neurofibromatosis. And I think that many of us would agree that this is one of the most challenging conditions that face pediatric orthopedists. So in a pre-fracture state, we oftentimes refer to this as anterolateral bowing of the tibia or congenital tibial dysplasia, which in this talk I'll refer to as CTD. And these patients really have a dual disadvantage. So they have unfavorable biomechanics due to the bowing of their tibia, and also they have poor bone quality or poor bone biology, especially at that apex of bone. So when we first meet these patients, the primary goal is really fracture prevention. And I think a lot of us use a clamshell orthosis and ask families to have their child, limit their activities. And then we wait, and despite bracing, a lot of these patients go on to fracture. And some fracture out of the brace, maybe it's off for bath time, some even fracture in the brace, and oftentimes patients fracture by 2 or 3 years of age. So once they do fracture, the goal is to achieve and maintain union, but the refracture rate has been reported as being high in multiple studies. And once this fracture does start to become a real problem, then you have kind of 3 main approaches to treatment. So you have resection of the pseudoarthrosis with grafting and intramedullary fixation. You have resection with circular external fixation, or you can have vascularized fibular grafting, or some combination of these approaches. But unfortunately, a lot of these patients go on to have repeated surgical procedures. They have prolonged periods of non-weight bearing and disuse, and many go on to have a chronic non-union. So for these patients, their life with congenital pseudoarthrosis of the tibia is often characterized by pain, deformity, disability, and many patients, due to the serial resections and then also the prolonged disuse, have a significant leg length discrepancy. Many go on to have continued angular deformity. They can have foot deformity, stiffness, and gait dysfunction. And due to these long-term risks and the psychosocial cost of all this treatment, some authors even recommend that you should start discussing the option of amputation early with families. And other authors or surgeons lean a little bit more towards kind of the 3 strikes rule, where you give a child 3 good chances to heal. And if they don't heal, then consider going on to amputation. So there have been multiple attempts over time to prevent fracture from happening. And there are multiple reports of attempting a corrective osteotomy. But unfortunately, this is high risk and oftentimes leads to an iatrogenic pseudoarthrosis. And in general, corrective osteotomy is not recommended. There's the McFarland bypass grafting technique using the fibula to act as a strut to try to strengthen the tibia. But reports of this technique have had a variable success and also lead to oftentimes residual deformity. And then recently there was a single case report of a patient who underwent guided growth with both at the proximal tibia and the distal tibia, and at 4-year follow-up had improved alignment as well as no history of fracture. So at our institution, Mark Dahl started using distal tibial guided growth in 2011 for pre-pseudoarthrosis congenital tibial dysplasia. Since then, both Libby Weber and I have adopted the technique, as well as now Andy Georgiadis. And the goal has been to improve mechanical alignment and hopefully decrease the fracture risk. So the purpose of this study was to evaluate our early experience with distal tibial guided growth for congenital tibial dysplasia. And really our primary question was, does this technique prevent or delay fracture in patients presenting with this condition compared to the known natural history? Our secondary questions included, did patients undergo any secondary or unanticipated procedures, or did they have any complications with this technique? Did patients have residual angular deformity or limb length discrepancy? And did patients undergo fibular procedures during the follow-up period? This is a retrospective review of a consecutive series of patients with anterolateral bowing of the tibia. We reviewed all the charts of all patients who were seen for this condition by Dr. Dahl, Dr. Weber, or me over the study period of 2011 through the end of 2017. And then we excluded patients who had a pseudoarthrosis or unstable fracture prior to 2011, those that had an unstable fracture or pseudoarthrosis prior to presentation, or those that had a really complex deformity that would not be amenable to guided growth. The charts were reviewed for diagnosis, age, surgical interventions, complications, and we reviewed all radiographs during the treatment period, making standard radiographic measurements, and each radiograph was checked for signs of fracture or pseudoarthrosis. We also assessed for cysts and recurrent deformity. We use a Crawford classification as pictured here, both to assess the tibia at baseline before surgery as well as at final follow-up. Due to the fact we did not include any patients that had a pseudoarthrosis or unstable fracture, all of our patients at baseline were Crawford 1, 2, or 3. And so especially Crawford 3 patients have cystic change. And then we also assessed fibula. So the technique we used, this was an outpatient procedure. We did it under tourniquet control, and we used an anterolateral incision centered over the distal tibial physis and made the incision in plane with the maximal plane of deformity. So oftentimes with guided growth, we would, in other areas of the body, you would center the plate really over the physis. But for this technique in particular, that distal tibial epiphysis is so small, really the most important part of the procedure is centering that distal screw within the epiphysis. So we'd hold the plate approximately where we needed it, but then really focus on centralizing that distal epiphyseal screw, advance the screw somewhat, then make sure the plate was vertical and place the metaphyseal screw, and then do that alternating tightening technique of the screws as described by Stevens. In some cases, to get better definition of the distal tibial epiphysis, we did use an ankle arthrogram. So depending on surgeon preference, we used either a soft dressing, the patient's own orthosis, or a splint postoperatively, and then all patients were returned to their clamshell orthosis within 4 weeks. And then they were followed up at standard intervals, as are most patients who undergo guided growth at about 3-month intervals, seen both clinically and radiographically. They underwent a plate exchange if necessary, if it appeared that the screws were encroaching on the physis or if the screws were becoming too splayed. And their implant was removed when the ankle was parallel to the ground, and also when mechanical access had been improved. We did recommend the patients use the orthosis until skeletal maturity, but then also many patients, as their leg became straighter, discontinued the orthosis, and we tolerated this as long as their alignment looked pretty good. So in our series, we had 10 patients who underwent guided growth for congenital tibial dysplasia. Again, this was a consecutive series. The mean age at diagnosis of this condition was just under a year, and the mean age at the first guided growth surgery was just about 2.5 years of age. 60% of our patients had neurofibromatosis, and if you look here in this second column, the second to the right, these are our Crawford classifications. We really only had one Crawford 1 patient, and the rest were 2s and 3s. And I'd like to highlight that we did have 4 patients that were Crawford 3, which indicates that they had a cystic change. Our mean follow-up after the initiation of treatment was just over 5 years. And at final follow-up, 1 patient was still undergoing treatment. For the remaining 9 patients that had completed treatment, the mean duration of guided growth treatment was 19.6 months. And 2 patients at final follow-up were still undergoing active fibular treatment. So with respect to our primary question, does this technique prevent or delay fracture? Well, in our series at the time of final follow-up, no patient had sustained a tibial fracture after the initiation of treatment. With respect to secondary or unanticipated procedures, I think a really important point here is that 60% required a plate exchange, and all of these first plate exchanges occurred within the first year of treatment. 1 patient had 2 plate exchanges, and 1 patient underwent a second course of guided growth. We did have 1 unanticipated return to the operating room. This is a patient who had recently undergone a plate exchange, and then on postoperative follow-up, it was noted that the screw had migrated into the physis right after that plate exchange, and so they urgently returned to the OR for implant removal. But I think it should also be noted that outside of guided growth procedures, no patient in this series underwent other tibial procedures. Now, with respect to residual angular deformity, we found that tibial alignment improved in all children. So these are the tables or the figures from our JBJS article. The top 2 represent diaphyseal alignment, and the gray vertical bar is kind of the normal range. And you can see that patients move towards normalizing. And then the bottom measurements are kind of the standard deformity measurements of LDTA and ADTA, and also patients improved alignment there as well. We did have one patient who did not achieve satisfactory mechanical access. This patient is shown here. You can see there's residual genu valgum, and this patient will, in the future, undergo proximal tibial guided growth for this. Now, with respect to limb length discrepancy, we found that one patient did have a clinically important limb length discrepancy at final follow-up, but of interest, the affected side was long. So historically in other studies, the affected side has been oftentimes the very short side, and actually in our study, the affected side was long. So this is the far right column here. The negative values are when the affected side is longer, and this patient here has a 3.6 centimeter limb length discrepancy. So you can see here radiographically, the patients with the arrows are the ones who are longer on the affected side, and it's the patient with the red arrow that has the affected extremity significantly longer than the contralateral side. So what about the fibula? We had 5 patients at baseline with dysplastic fibula or pseudoarthrosis, and at final follow-up, we still had 5 patients with fibular involvement. 3 had pseudoarthrosis and 2 were undergoing treatment. 1 was still dysplastic and 1 just had mild bowing, and 3 patients underwent fibular procedures. With respect to the radiographic appearance of the tibia, again, we started out with 4 patients that had cystic change, and at final follow-up, only 1 patient had a cyst present radiographically, and that cyst had significantly improved in appearance. And with respect to the Crawford classification, pre-op status, we only had 1 Crawford 1, which is the mildest type. And then on final follow-up, we had multiple Crawford 1s as represented here. I do want to show you what our residual cysts look like. So this is a patient with a cyst, and this is near the time of initiation of treatment. And at final follow-up, you can barely see the cyst, although it's right there at the arrow, and you can see that there's been significant involvement. And another example of a patient with a cyst, this is our patient who actually had our longest follow-up. She had significant cystic changes early on in treatment, and at final follow-up, 8 years after initiation of treatment, you can see that there's complete resolution of the cyst and overall improvement in the bone quality as it appears radiographically. So with respect to complications using the Clavien-Dindo system, we did have 4 complications in 3 patients. That said, 3 of the complications are Clavien-Dindo 1, so they did not even require really a significant change in management or even a prescription. Our only significant complication was the unanticipated return to the OR for the screw migration, which I already discussed. So again, we had 10 patients, mean 5 years of follow-up, no fractures, alignment improved, the dysplastic appearance improved, and length was preserved. So how does this compare to the literature? Well, really, there's very limited data on fracture-free patients out there, largely because so many patients go on to fracture. And again, studies show a mean age for first fracture at 2 to 3 years. A recent meta-analysis reported that while 75% of patients achieve primary union after that first fracture, that union is really tenuous, and about 35% go on to refracture. And if you look specifically at those longer-term studies, not surprisingly, the longer you follow patients, the higher that rate of refracture. So what if we only really are delaying fracture this technique? Is that meaningful? And we would argue yes, and the literature supports that. So Dobbs reported that when patients were older at the time of first fracture and pseudoarthrosis, that they actually had a lower refracture rate. Jim Roach reported that on a series of patients that fractured late and reported that they had a milder course and a better prognosis. And then Lori Carroll looked at 2 groups of patients, of those that had fractured before age 4 and those that had fractured 4 years and later, and reported that the older group had improved gait function, they had fewer surgical interventions, and had less transankle fixation along the way. So we do think that even fracture delay is likely of benefit. So how does our series compare to other surgical interventions for fracture prevention? Well, there's an EPOS study that reported on 19 cases who had final follow-up only had 7 intact tibia, and only 1 was described as straight. And there's another report of using the McFarland technique where 6 of 9 were successful. I would say probably the most similar series to ours, if you're comparing this technique to the McFarland technique, would be a study out of the Children's Hospital of Philadelphia. And they reported 10 out of 10 successful cases at 78 months using this technique. 0 out of 10 of their patients sustained a fracture, which is the same as what we reported with our study. But they did have persistent deformity where they had significant coronal and sagittal angulation at final follow-up, which was significantly higher than our residual angulation that we reported in our study. And I would also like to highlight that the McFarland technique is fairly invasive compared to our relatively minimally invasive technique. And the last study to compare ours with was the one case report in the literature that exists on this technique, but they use both a proximal plate and a distal plate. So in both studies, you've improved alignment and no fracture. And in both studies, you're really leaving that soft tissue envelope around that fragile apex intact. But as I showed you in our kind of patients with their mechanical alignment, most of our patients did not require proximal tibial growth modulation. We have the one patient that will go on to likely need this. And so we think that in most patients, distal tibial growth modulation should be sufficient, but you can keep an eye on their alignment over time. So the strengths of our series are that this was consecutive. This is a very rare condition, and we think that 10 patients that present pre-fracture at one institution is a fairly large series. Our limitations are that this is a retrospective study, so we have the same limitations of other retrospective series. Our sample size is too small for meaningful statistical analysis. We don't have a comparison group other than historical controls, and our patients are not yet skeletally mature. But at this point, based on our experience, we do recommend distal tibial guided growth for patients with anterolateral bowing who are pre-pseudoarthrosis. And this is really first-line treatment here now at Gillette. The benefits of this guided growth technique is that it's really familiar to most of us. It's an outpatient procedure, it's minimally invasive, and it does not involve the surrounding soft tissue envelope around that fragile apex. I do really want to emphasize, though, that close follow-up is needed because many of these patients need implant exchange within the first year. We think this technique seems to provide a functional extremity, it preserves length. In our patients, they've been fracture-free, or at least a delayed fracture, and in general, the burden for patient and families has been minimized to date. In the future, we clearly need a larger series, more institutions, and longer follow-up. Thank you again for the opportunity to present this information and this technique.
Yeah, thank you so much, Dr. Lane. That was an excellent paper. And CPT is acknowledged as one of the most difficult conditions to treat in orthopedics. And it's really exciting to know with a technique as simple as growth modulation, we may be able to prevent CPT in a selected group of patients. So coming to my first question, with this technique, with the simple mechanical realignment, you have been able to prevent and establish pseudoarthrosis. Not only that, you have also shown that the biology improves. If you look at your charts, many of your Crawfords type 2 and 3, who were pre-op type 2 or 3, they have been converted to Crawford type 1. Do you have any theory as to how this, biology improves with a simple mechanical realignment? Any mechanism how it might be happening?
Well, thank you for that question. It's something that we discuss frequently. And why does the biology improve when you correct gradually? And it doesn't necessarily improve when you correct it acutely, right? Yeah. And so, I mean, it must do with the forces across that apex, and that children are able to continue to weight bear as that apex gradually kind of decreases in magnitude, and that you're just normalizing the forces there, and it allows them to normalize the biology. But clearly, I mean, we need to study that as well. We've been considering getting kind of MRI along the way, also to see if we can gain more information on the underlying changes in biology. But it's kind of a pleasant surprise along the way with this technique to see those cysts resolve and to see just the overall kind of biological appearance radiographically improve.
Yeah, makes sense. So the next question I have is, many of these patients you diagnosed with anterolateral bowing at an average age of 11 months, but the surgery was offered only around the age of 2 years. Now, this intervening waiting period, between the age of 1 to 2 years is a very, tricky period where many of the kids that we see, they fracture during this age group. And I saw from your charts that there was one child whom you saw and you had you thought he would be doing a growth modulation at 2 years, but then he fractured before that, and therefore you had to exclude him for that. So in view of this, is there any consideration or, any justification where you might consider, further advancing the age of growth modulation? Like you are now doing it at 2 years, but maybe get the age a bit lower, maybe use smaller screws, maybe 2.5 screws to start with, and then exchange with a larger plate? Or do you think that, that might be, dangerous to the distal physis? Your views on that?
So thank you for that question. And actually, your question very much reflects what our more recent surgical experience has been, that we are oftentimes now signing patients up for surgery pretty much right after we meet them, as long as we think that they can tolerate implant size, and we've been working with smaller and smaller implants. So I think that our youngest case to date here was done, I think, just 2 weeks ago. So I have no follow-up for you on this, but Dr. Georgiadis has a patient who I think was 7 months of age or 8 months of age. And then I also had a case, I think about 3 weeks ago, and the child was 18 months. You're clearly challenged by the anatomy. And so it's very helpful to use an arthrogram. I think in my case, I ended up using 3/5 cannulated screws instead of 4/5. You have to make sure that they don't pull through the plate. And then also, I think that Mark Dahl has taken kind of 1/3 tubular plates from the mini frag set and cut them to size and use like 2/7 screws. But I would say that delay from diagnosis to treatment in our series probably represents more that we're kind of working to adopt this technique, and it wasn't yet kind of first line treatment here yet. We're still kind of figuring out if it worked. And now that we have this series, we have repeated cases of success, that we are becoming more aggressive with operating earlier. But I don't have any follow-up on those younger patients yet.
Okay. So the next question, which I think Jayant also had this question as to, can you elaborate on your management of the fibula pseudoarthrosis? What was the timing and what were the procedures that you did? Was it an attempt to achieve end-to-end fusion of the fibula, or did you achieve a tibia-fibula syndesmosis? And was that after correction of the tibial deformity that you did it?
So there are 2 cases where the pseudoarthrosis was addressed. Both of these are cases of Mark Dahl. And this was, both of them had, I believe, multiple procedures, and oftentimes with grafting and intramedullary fixation. And I believe one patient also had the addition of BMP. There was not a case in this series of doing a synostosis. We do have a patient who has a pseudoarthrosis right now that has not had treatment. And the other patient that had fibular treatment actually has this really long bowed dysplastic tibia, or fibula, excuse me. And so they underwent an epiphysiodesis of the distal fibula temporarily to try to normalize that differential a little bit more.
So there was one case which I noted where you have said that there was a stable tibia fracture, and you went ahead with a growth modulation in that. So can you elaborate, how do you differentiate between, a pseudoarthrosis and a stable tibia fracture, and why you selected this case for a growth modulation? And did the fracture heal with just a growth modulation?
So this was actually the first patient in the series. And so she was one of those cyst examples that I showed. And I can also bring it up again if that's helpful, but she had this oblique lucency that appeared radiographically, that there was concern that this was fracture, but before proceeding with growth modulation, Mark Dahl took her to the operating room and stressed it to see, was this really an unstable fracture, or was this just either a partial fracture or kind of just a lucency within the dysplasia? And he did not see any signs of instability or displacement, and so felt comfortable proceeding with growth modulation. And then she also, as I showed over that 8-year period, that her dysplastic appearance, including that oblique lucency and that cystic change, resolved over time. But we do not have experience in patients with unstable fractures being treated with guided growth at this institution.
So we'll go to a few questions from the chat box. Jayant is asking, can this technique be employed in children with an established pseudoarthrosis, but parents want to defer definitive treatment? I have one child who is undergoing chemo for a concomitant optic glioma, for instance. Any thoughts on that?
We just don't have experience with that to be able to comment.
Okay.
And so really, I mean, our indications here for this technique are patients without pseudoarthrosis. But clearly this technique is new for this condition, and so there may be broader applications in the future. We just don't have data or experience on it.
Dr. Vivek is asking, I think you have already addressed this point in your presentation, but after the alignment and cystic changes have improved, how long do we protect the leg in the orthosis? So you mentioned that you would like to go till skeletal maturity, but most children don't. Yeah. So your experience with that?
I would expect that experience is sort of worldwide, that patients don't always listen to us about brace use and continue to use their orthosis as long as we want them to. But especially once they're done with guided growth treatment and and their follow-up becomes a little less frequent, a lot of patients self-discontinue the brace, even though we recommend it. And truthfully, once they're doing really well and have been fracture-free for a while, we tend to tolerate that discontinuation. But we encourage brace use until skeletal maturity.
But till the mechanical realignment, you will definitely very forcefully insist that they wear the brace till the mechanical access.
So I should be very clear that this is growth modulation with brace use in this series. So it's combined treatment.
So Dr. Taral Nagda is asking, corollary to your findings in treated CPT with osteosynthesis who have secondary deformities, would the deformities predispose to refractures and can be prevented with similar procedure? So for example, maybe an ankle valgus is, what is a common problem in a treated CPT. So would you consider this as a treatment modality in residual deformities following CPT treatment?
I think you certainly could. I mean, I think that any treatment that stays away from that fragile apex of bone and any treatment that is fairly low risk, like guided growth, I think seems reasonable. Again, we don't have a lot of experience to report on with that, but I mean, our complications are really quite low, and we think that this is a low risk procedure. Now, one thing with this patient population is that I think clearly we need to follow them over time. I mean, our oldest patient is just under 11 years. And so I think especially those patients that still have a problem with the fibula, I mean, this treatment clearly does not resolve the fibular pathology. And so the patients that do continue to have a fibular problem, I think especially as like Charlie Johnston has pointed out in his studies, they may go on to have ankle valgus and a problematic, ankle alignment long term. And so we'll just need to follow them and see what other kind of treatment they may need.
I saw that your series, there was one child who required reapplication of 8-plate after an interval of a few years, I guess. Mm-hmm. And that child had a intact fibula, which was long. So would that you consider that to be a risk factor for recurrence of the deformity?
So I actually have images of that patient that I can share right now, if that would be helpful. Let's see if I can do this quickly. You see those slides there?
Yeah.
So it's fairly limited. This patient actually had fairly mild tibial deformity, but had a very long dysplastic fibula. And they went on to have distal tibial guided growth, and initially nothing was done with the fibula. And then I don't have all the images along the way ready here, but there's some thinking that long fibula was kind of driving the distal tibia back into some varus. And so they did undergo repeat growth modulation of the distal tibia, but then also underwent an epiphysiodesis temporarily here of the distal fibula. And in talking to Mark Dahl about this case, he wishes that he had addressed the fibula earlier. And then this is that patient at final follow-up. And this is the one that also had a significant leg length discrepancy where they're over 3.5 centimeters long on the affected side. But that's our only case of recurrence, and it really seemed to be kind of driven by the fibula. So I think in the future we'll probably pay a little bit more attention to that fibular length and alignment as well. But I don't have data necessarily beyond, well.
So what was the interval between these two growth modulations, between these two 8-plate applications?
I'd have to look back to the tables. I mean, here we're at 2 + 9 and he's nearly corrected. And then here he's being treated again at 6 + 2. So
okay. 3 to 4 years.
Probably a couple years between. Let me unshare.
Fine. Thank you so much. Are there any more questions? Alric, anyone would like to ask from the panel?
Yeah, I would really love to ask Jennifer.
I think, madam, your voice is crackling.
Sir, your audio is not good. Can you type it in the chat box?
This is Tom. If I could make just a comment while we're waiting for her to type it. You know, Jennifer made the point that the oldest patient in that series was the very first patient. So it's a very early experience. You didn't know how it was going to work. So you're really quite conservative in your indications. And exactly the same thing was true for us with the DFEO PTA. When we first started, you know, this was uncharted territory. So you were only doing it on the most severe of patients. And then it was after we had the experience that it was a safe and effective procedure that we started to apply it more broadly. So, and we've now got almost 30 years of experience with the DFEO and PTA, and only 10 years experience with the 8-plate for the congenital pseudoarthrosis. So it'll be very interesting to see how that evolves and develops.
Great, thank you so much. So if there are no further questions, I think I must really thank all our 3 authors today. We have had a really wonderful session. We were looking forward to this for quite some time, and I must say we have really lived up to the hype of both these papers. Tom and Liz, I really thank you for this wonderful paper on the long-term effects of DFEO and PTA. We've been students of you and learning from you the technique of DFEO PTA, and have watched throughout the years how you have shown us consistently, not just the surgical technique, but then short-term results, and then even now, the longer results of this procedure. And I think this is really a wonderful, honest appraisal of a new technique which has been described by your center originally. And it's information like this which really adds value to orthopedic literature. You know, very often techniques come in and go away, and we lack the long-term data that comes from the parent center itself. But I think this was a really wonderful paper that we thoroughly enjoyed, showing us a very balanced view of the effect of this type of surgery. That in the short term, it does look really good. In the long term, there are benefits of the surgery, no doubt, and the reasons why it's not making much of a difference in the quality of life, activity, participation under the ICF classification, maybe just that those values have so many other things that require to be taken into account. So no way detracts from the value of this very important procedure, I think, that all of us orthopedic surgeons have added to armamentarium and have really seen good results over time. So thank you so much for that wonderful paper, both of you. And Jennifer, of course, I think one of the things of 2020, besides the figure of the coronavirus that we have all got used to, I think a beautiful panel of X-rays, which have shown the sequential correction in all those 4 figures that you showed in your paper, has been something that has really been ingrained into us. It is such a powerful visual tool, which much more than all those, the text that you have shown as a very simple procedure, but showing us sequentially, really beautifully how over time, in this very small cohort of 10 patients, which of course is a big number for CPT, that we have another procedure now in our hands where we can intervene earlier rather than later in treating this very difficult problem. So thank you very much, all of you. And thanks again to Dr. Dhiren, Sandeep for supporting us in this venture. Thank you for all our attendees. I can see James Wee, who's been attending right from the first Meet the Authors session that we've had, and also Prasad Gauruneni. I also see Saurush on this panel. And if I miss anyone else who have joined us from abroad, thank you again so much for encouraging us and supporting us with this venture. We will be having some more such sessions over the next few months. And I'd like to thank all of you for participating today. So have a great weekend.
Thank you so much for this opportunity and great discussion. Really appreciate it.
Thank you very much.
Thank you.
Bye.
Thank you.
Thank you,
Bye.
everyone.
Bye.
Bye.